And it's also mandated by the regulatory nursing boards that nurses have to have this concept-based scientific knowledge in order to give drugs. From the literature, we had found that immersive 3D technology can enhance understanding of complex scientific concepts, but we needed to actually see if it would work and if it would actually enhance the knowledge. But we also were mindful that there are some problems with 3D visualizations, that they can trigger motion sickness. So we always also wanted to see if that was the case. So we actually, in drug therapy, I have undergraduate nursing midwifery students. There's about 400 students in this course, and it's across 3 campuses. So we undertook this study at the main campus, and we had 2 groups. We had a 3D visualization group, and then the other group watched this pharmacology artifact on a 2D widescreen. And we built an artifact showing how drugs attach at receptor sites, and then aim to look at how this affected the nurse's knowledge and satisfaction, and then also that element of comfort regarding the motion sickness, which is referred to as cyber sickness.
Okay, so you can see on this slide here that these are the 2 examples of the environments that we use that Julie was just speaking about. A number of you will have perhaps heard me present previously on Cave 2, which is one of the, was initially the primary environment that we designed this artifact for. It has 80 3D LCD 46-inch panels arranged in 20 columns in 4 rows. So we're looking at basically about 84 million pixels. With a very obviously high resolution, and we also use passive circular polarized filters with horizontal interlacing, so we don't have many problems in terms of the presentation of the image. We have an 8-meter diameter, so it's quite a large space. And it also has tracking, etc. The sort of software that we're using, everything that we build is in Unity. Basically, in this artifact that we're talking today about is a Unity project. We also use Get Real 3D Unity extension, basically for using it in Cave. So just to give you an example of the artifact itself, there's a few still pictures here of various parts of it, but it really doesn't actually give you any idea of, you know, how it works. So obviously 3D, obviously animated. So I've just got this little clip, a very small one here, that actually shows you you know, some of the parts of the artifact. We've got a neuron here, and we do have a flash of an electric impulse. The skeleton that we can actually look at in terms of all its various components. And then specifically, we're looking at the chest in the case study for this particular artifact. And here we're actually looking at some of the concepts related to transmission of medication and receptor theory.
Okay.
So, Julie.
Yeah, so we built that artifact from scratch, and we actually had a design team that helped us to put that together. So we're very grateful to that level of knowledge that we were able to access in order to build that artifact. So we had the 3 main aims, and really we just wanted to see if it was effective on the undergraduate nursing and midwifery knowledge of drug receptor binding, and we compared that to a 2D exposure. And we just wanted to find out if the students were satisfied with their learning using these types of visualization technologies. And we also wanted to see if they did experience any discomfort or motion sickness. And we just described that as being like headache or dizziness or a feeling of feeling sick when they were actually in the cave. Next slide, yes. So this location was where Petrea showed you on the map. It's the School of Nursing and Midwifery in southeast Queensland. And we just did the study at the one main campus, even though we have 3 campuses. We had 226 second year students enrolled in the Bachelor of Nursing Science degree or the midwifery dual degree. And of those 226, 202 consented to be involved. So we used a 5-stage structured process just to make sure that we got the optimal learning from the actual activity as well as running the study. So before we went into the cave, we did a pre-brief, and the pre-brief involved explaining, you know, what we were going to do for the day, what the learning outcomes were. Obviously, we needed to get consent at that point as well. And we also talked to the students about what to do if they did experience any discomfort. So usually what happens is the student just removes the glasses and lowers their head and doesn't look at the visualization any longer. But if that doesn't work, then they are to leave the room and to sit down, and there was somebody outside who was available to sit with them if necessary. So after the pre-brief, the students did a pre-test. So they just answered 5 questions. Then the students went into either the 3D visualization or the 2D screen. When they came out of either 3D or 2D, we actually went through a case study that involved how drugs attach at receptor sites, and specifically a particular drug called a beta blocker, which has an effect on the heart. After we'd done all of that, we did a post-test, and then we did a debrief, and then we gave the surveys out, which was the satisfaction survey and the comfort ratings.
I think it's important to just note here that with regard to the pre-test, all of these students had what we would call a traditional delivery method. So they've had the lectures, they've had all the online materials, etc., etc. So technically, if we weren't using this technology and this particular artifact under normal circumstances, we would have expected that they would know this content. And so they should have all been starting at an informed position. The results actually were a little bit interesting though.
So this is just a breakdown of those 5 stages again, which involve pre-brief, pre-test, 2D or 3D, post-test, and then a structured debrief. These are the 5 multiple choice questions that we used in both the pre and post test. They were the same questions, but they came to each student in a random order. And students that were not doing the activity at the time didn't have access to this test because it was password protected on the day. So really it was just asking about what their knowledge about how drugs attach at receptor sites. The instruments that we used then to collect their satisfaction was a modified satisfaction with simulation experience scale, which has 24 questions and has been tested for validity with Cronbach Alpha. And it just asks satisfaction questions in 3 domains. So students were asked if they were satisfied with the debriefing and reflection. They were asked questions about clinical reasoning and about clinical learning. We made minor word changes to 10 of 24 questions just so that we could talk about visualization rather than simulation. So it's just a minor word change. But we did add 2 questions at the end. Question 25, I believe the visualization will enhance my understanding of patients' conditions and the treatment of those conditions when it's taught in other courses. So we were alluding to the fact that they might be able to transfer this to other contexts. And then 26, we wanted to know about the feelings of discomfort. And then after that question, whether they said yes or no, there was then a Likert scale, and they could rate whether they had experienced any kind of sickness or headache or any discomfort. Yep, so the comfort ratings were, it's a 10-point ordinal scale ranging from 1, no discomfort, to 10, incapacitating. So that's just a table about the knowledge acquisition. So this was our colleague Peter Dunn, who is a statistician. Peter did all the data analysis for us. So I'll just move to the next slide. Basically, there was a statistically significant improvement in the post-test scores in the 3D immersion group. Now, with the satisfaction scores, the students were satisfied with both the immersion techniques, so they enjoyed both 2D and 3D. The scores for the 3D immersion were higher for each subscale, but they weren't statistically significant. But the scores for the 3D immersion were higher for each of the individual satisfaction questions, except for questions 5 and 14. But there was only a statistical significance for question 21, which was the visualization enhanced my understanding of the autonomic nervous system and how this system controls resting heart rate. And question 25, I believe the visualization will enhance my understanding of patients' conditions. The 3D immersion mean was higher than the 2D immersion. Mean satisfaction scores. So that's, again, that's just a table just to display the satisfaction scores. Next slide. And so basically to interpret that, the 3D immersion actually caused very little discomfort to students. And there's no evidence that the immersion techniques differ in terms of their discomfort proportions. So essentially what we found was there was minimal sickness, motion sickness, headaches, dizziness. And I think it's probably because the actual artifact that we used, it didn't move very quickly. It didn't behave like a roller coaster like it does when you have like a headset and it might be Oculus Rift. It was quite slow moving, and we think that's possibly one of the reasons why we didn't really get any discomfort. Also, students were watching this passively. They weren't actually controlling how it moved or getting like a headset on, and so they didn't really seem to have any discomfort from this.
I think it's of note to say that from our experience with students in CAVE, that because they are passive viewing and because they have peripheral vision and are very obviously planted, if you like, in reality, that they seem to have less discomfort and less problems than students that we have using other devices, and that includes headsets of various forms and also using stereoscopic lenses and handheld devices, which I'll talk about in a minute.
So the outcome of this project, we published this. So there was myself, Petrea, and our statistician, Peter Dunn. So this was published into a nursing journal. So
this particular project, we have extended it. Basically what we've done is we've replicated the design, but in terms of responding to the needs around equity and the fact that we have got an expanding footprint in the university, so we've got multiple campuses, we needed to address the fact that regional campuses did not have a CAVE, did not have access to the same facilities. So what we did was we used the same artifact, but we designed it so that we could use it using a handheld device, in this case students' phone, and we used attachment stereoscopic lenses that you can see in these particular pictures here. And as you can see, the student literally commences the artifact and holds their phone up to their face. And then engages with the learning artifact. So what we've done here is basically we actually refocused our research questions, and so we wanted again to look at what the effect of CAVE on quiz scores compared to handheld devices would be, and what the effect on satisfaction scores were, and also again looking at comfort, but in all three situations, basically comparing a CAVE experience to a handheld device experience. So you can see here from the summary of findings, while we had a smaller group with the handheld device, the student satisfaction was very, very high, and they also responded positively in terms of clinical reasoning and clinical learning. One of the things, though, that we did find was that the handheld devices caused more general discomfort and compared to those that were actually in cave. So our conclusions in terms of where we are at our work at the moment, and it is still continuing, is that using 3D technology has been successful for us in increasing the percentage of students' responses in terms of post-test questions. So as far as knowledge acquisition goes, we're really pleased with the outcomes of using the cave. Also, we're pleased with the student satisfaction ratings, particularly with the visualization experience, and the fact that minimal discomfort is associated with the stereoscopic virtual environment. And for us, that's actually been quite important, because in terms of actually looking at acceptance of using 3D technologies, we have had some pushback in the academic community, and the first thing that people will say is that, oh no, we couldn't possibly do that, you'll make everybody sick. And so in terms of actually being able to put evidence out there to show that students have got increased knowledge acquisition, and it can be done in an experience which is in actual fact not only positive in extending their ability to prepare for clinical practice, in this case nurses, but it is a comfortable experience, has been really important for us. There is one other just wee thing that I'd like to mention here in terms of making the comparison between cave and handheld devices, and that was that overall, in terms of looking at the scores as student achievement, is that the students that use the handheld devices, their scores were slightly higher than what the students' scores were in cave. Now, obviously, we're investigating that further. From the interviews that we've done with students and talking with them, they've said things like using the handheld device was really good because they can control it. So if you're in cave and you're actually having a facilitated session, you're going with the flow. You might have a question, you can ask the lecturer, they will answer it. If you still don't get it though, it's not likely that you're going to keep answering questions, because obviously we're moving along and we've got certain things that need to be achieved in a certain time frame. However, if you have a handheld device, you can actually stop that artifact at any time, and you can replay it as many times as you need to until you get it. And while statistically all the scores were higher than those that didn't use 3D devices, we're just wondering whether or not the self-control mechanism and students being able to revisit those components of the visualization that they didn't understand has actually had an influence here. So that's our presentation today. We would invite any questions.
All right. All right, very good. Any questions? All right.
Hi, can you hear me?
Yep.
My understanding is that you are trying to measure motion sickness in a cave. Have you considered using force feedback along with the projection, like a chair with hydraulics or some sort of a motion that match the projection, like we see in an amusement park or something?
Yeah, no, we haven't, and our particular cave doesn't actually have a floor. I mean, ideally we could actually put somebody on some sort of levitating device and actually move them around, but for the purposes of the types of educational artifacts that we're using, we don't need to do that. The artifacts themselves move, and the animation as such actually provides the technical views that students need to understand complex physiological states that normally you wouldn't see in a textbook. So we haven't done that, and I personally don't see why we would, but if we were doing something that was involving perhaps sports science, and where, you know, people are actually going to be moving around and what have you, that would be a really good idea.
Thank you.
Another question here, can we just...
I was glad to see that you reported minimal discomfort in your participants, but at the same time you had one with severe symptoms and one with that you listed as incapacitated. I don't think I ever had anybody that I would describe with those kind of symptoms. Can you elaborate a little on that so that we know kind of like what to watch out for as the worst case scenario?
Sorry, I didn't quite hear that. But you've identified that there was someone that actually had a severe reaction, is that correct?
Yes, that's correct.
Yes, okay, so interestingly, because we've only used an ordinate scale where students actually rank themselves, we probably actually need to look a little bit more deeper in that in terms of getting better description of what it is. That particular student, we do know, in actual fact, did have a ear, wasn't it, Julia? She had a
congenital abnormality on her ears, and she did have difficulty hearing things, but she was adamant that she was going in the cave, and she didn't want to be left out. And so we said, okay. So I sat with her the entire time that she was in the cave, but she did have to come out of the cave because it did actually make her feel quite dizzy. But being a nurse, we were quite happy to let her go into the cave, and then I just assisted her to come out of the cave when she was affected by this. But she was absolutely adamant that she was having this experience and she was not going to be left out.
Yeah, so someone with a middle ear problem like that, it wouldn't really surprise us. And that's probably why has had some impact, and she definitely was the outlier in the study.
Yeah.
Mm.
Thank you.
Thank you so very much for the talk. It was really fascinating. I have a methodological question. You had a slide in there where you listed p-values. If you could just maybe go back a couple of slides. You were also listing the sample sizes for people in the cave versus people using 2D. And it seemed like your sample size for the cave was much, much higher than for the 2D visualization. I'm wondering if I saw that correctly, and if so, why exactly those sample sizes also different?
Yes, we did have problems with the sample size because on the day we were randomly allocating students to whether they went into the cave or whether they used the handheld devices, and for some classes they found it difficult. We had some technical issues getting the stereoscopic 3D artifact to work on some people's phones, and so the tutors that were involved in that particular class then would just default to the cave, and they would say to students, okay, if you can't get this working on your phone, that's okay, just go in the cave. So it wasn't perfect in terms of trying to get to balanced sample sizes, and it was really due to technical difficulties trying to get the artifact to work on a person's phone. When we talked to the statistician about whether that was, whether that was problematic in the fact that the two sample sizes were different, he actually did say to us, it increases the risk of a type 2 error, and he was aware of that, and but he still felt it was okay to report this. But one of the limitations was the fact that we did have those technical problems with the phones, and so quite a few students, they just abandoned it then and just went in to have the experience in the cave.
Yeah, I think that's actually an important lesson learned, actually, because one size doesn't fit all. And, I suppose we had made an assumption that, you know, students had a phone, it would be a device, it would be compatible. Some of them didn't have what was needed. In fact, some of them didn't even have the ability, they hadn't downloaded the appropriate app for YouTube. And that was the main method that we were using, the university YouTube channel, to actually push this artifact out. And it was actually quite surprising in terms of what students, supposedly this great digital population, knew about the devices that they were using and their capability. But you know, it is something worthy of comment. So thank you for that.
Thank you so much.
Thank you.
Great, looks like that was the last question. So that's our last session for today. Thank you, doctors.
Have a good evening.
Thank you very much.
Thank you.